Welcome to the Learn Skin podcast with me, Dr. Raja.
And me, Dr. Hadar, where we discuss all things skin.
Join us as we delve into the art and science of skin health in today's episode.
Hey, Raja, can you say the thing I told you to tell them?
Of course. We are board-certified dermatologists. This podcast is meant for educational and informational purposes only and is not considered medical advice, nor does it serve as a substitute for professional care by a doctor or other qualified medical professional. All opinions shared do not express the views of Learn Health, Inc. Let's get to the good stuff.
Hey, Raja, how are you today?
Hey, Hadar. You know what? I have a feeling you don't know JAK. Or do you?
Oh, my friend, you are bringing up a topic that we really should discuss. We've been talking a lot about various different treatments, but the new hot stuff that's coming into every clinic in America and beyond are the inhibitors of the JAK-STAT pathway. So we really need to go through this because it can be so confusing. There's so many molecules and, what are the indications? There's like a gazillion trials happening and I'm getting a little nervous, a little confused. I'm getting a little jacked up, my friend. Can you help me?
I was waiting for the pun to drop. It finally did. I was like, when's he going to do it? Hey, you know what? It's one of my favorite people. I know that you would fall in love with this guy. I think you guys have already met in person, but man, this is Dr. Jason Hawks. I love the way he talks about stuff. He's really thoughtful and he is an expert when it comes to thinking about JAK inhibitors. And he is also an Associate Professor of Dermatology at UC Davis, amazing clinician, great at teaching, and we are super thrilled to have you on the podcast. Even if your fantasy football team might not have as much attention to it because we're talking here, we appreciate you coming on.
I'm happy to be here, both of you guys having me. And my fantasy team actually is pretty good. So if anyone wants to come challenge, I'm all up for that. But I get equally excited about the JAK inhibitors. So happy to talk about some of the things we're seeing come forward in psoriasis.
Yes, absolutely. And I think you're the perfect person also because you have pretty strong background in immunology, right? You've done some work there.
Yeah, definitely spent a lot of time in immunology, both at the bench where I've done, cell culture and mouse models and a lot of the laboratory science, but also into clinical trials where we do a lot of the same type of approach to human tissues. So that's really the space I like, the immunology, that translational immunology, where we can take a concept like we'll talk about today and then apply it to actually using it in the clinic where some of the other laboratory science can take many years to come, but we're getting these new molecules where we can take them right out of these trials and then start applying them to patients we're seeing in the clinic. And that to me is the sweet spot.
I mean, this is awesome, Jason, because you've got that basic science background. Actually, Hadar, you've been in the basic science world too. I think it actually is really helpful to have that experience because I think biochemistry isn't as intimidating. So on that note, Jason, can you take us through these JAK inhibitors? I mean, they are taking the medical field by storm, especially within dermatology. And I know we're going to focus in on psoriasis, but can you give us a background? What are these JAK inhibitors?
Yeah, I mean, something that catches a lot of attention doesn't necessarily mean it's better, but it's certainly this hot topic. And I think when you take these molecules, the class of molecules in the context of where we've been in dermatology, in some ways it can feel like a step backwards. And I'll explain what I mean because we've had a lot of medications, which are these small molecules. So, methotrexate, cyclosporin, even apremilast, these are small molecules that kind of work more broadly. And that makes sense with the immunology of small molecules because they enter inside cells where they can have a direct impact on the genetic material and DNA and affect genes. So being able to get into the cells, they can have sort of broad acting mechanisms, but they also tend to hit pathways which contribute to multiple processes. And that's very different than what we've seen happen over time. We went from these small molecules like methotrexate, cyclosporin, acitretin. In psoriasis, we moved to apremilast, which is a little more focused, less broad acting, but then into these biologics. And these biologics have had a huge impact in the field, but they're very different molecules where they're larger proteins. They can't get inside cells, so they act extracellular outside the cells. And they rely on the inside pathways, these messaging pathways to communicate a signal. And so we've really come kind of full circle where we had these broad acting small molecules now to very specific, targeted, very focused acting molecules like the biologics. And now we're going kind of in the middle, which are, again, broad acting medications, but less broad than the traditional methotrexate, cyclosporin, etc. So we've really got to go backwards in terms of thinking how they work. It's not a step backwards in progress, but in terms of how they act in the body. So this has really created a lot of attention, excitement around, what are these molecules and how do they work?
You know what I find interesting about the biologics is that they were so specific that sometimes it was a little bit difficult to cross over into multiple diseases, right? Like a psoriasis biologic really rarely has activity, if anything at all, and like in, say, atopic derm and vice versa. But with the JAK inhibitors, I'm seeing that there's some versatility, but can you talk about this versatility? I mean, people talk about pan JAK inhibitors versus specific JAK inhibitors, like a JAK1 specificity or a JAK3 or whatever it is. Can you speak to that? Like, how specific are we getting when we say specific? And, how many pathways are we blocking?
Yeah, so I think there's some important terminology here that I think is really important to clarify.
Yes, I'm a little lost. Guide us for a second. There's 4 of them, right?
Yeah, so we'll kind of come to the JAK inhibitors in terms of the isoforms, but I think concept, Raja, you mentioned specific, but we need to be clear about specificity and selectivity. So when we think about the biologics, we're talking about a molecule this protein that's very specific for a target, right? So maybe it blocks TNF or IL-17A or IL-23P19. And they're specific because they act on a specific target. So we really have limited off-target effects. It doesn't just hit multiple things.
It's like a targeted missile, right? We see a lot of those on TV, right? It's kind of hones on the target, really cleanly gets the target, not a lot of damage around, not a lot of side effects, really gets there, right?
Right. I usually, in the clinical, explain this to patients as being kind of like a sniper, right? It really can hit one thing. Now, being specific for a target doesn't mean that it doesn't hit more than one thing. A good example is ustekinumab, which blocks P40, which targets IL-12 and IL-23. So specificity doesn't mean it hits one thing. It just means it's specific for a target. Now, that's different than speaking about selectivity. And that applies to the JAK inhibitors because, as Hadar just mentioned, we have 4 JAK isoforms or enzymes. So we have JAK1, JAK2, JAK3, and then TYK2, TYK2. And the molecules that we've created, these new medications, they're selective for a specific JAK isoform. So it might block or inhibit JAK1 or JAK2, for example. And the reason we use selectivity here is because blocking JAK1 actually has a broad impact because JAK1 is used in multiple other pathways, right? So where one molecule with biologic blocking a particular cytokine has a very specific effect because that cytokine interacts with the receptor, we got to think about the JAK family as being the main pathway that communicates the message outside the cell with a cytokine, for example, and it's the in between linking the change on the inside. So when you have these 4 JAK isoforms, they only have 4 of these molecules that are mediating pretty much all of the cytokine signals. So there's redundancy. And so if you block just one isoform, you're actually blocking the message from many cytokines. And in that way, while the JAK inhibitors are selective, they're not specific because they have this broad impact on multiple cytokines. And that's the biggest difference between thinking about biologics and the JAK inhibitors. And as Rasha, you mentioned this idea that sometimes being so targeted can be problematic. And I think that's really where we get into the use of these JAK inhibitors because sometimes we have conditions that are a little messier. So I'll give you an example, like psoriatic arthritis is very different in terms of the immunology of the skin with plaque psoriasis. So sometimes we need to hit multiple pathways because hitting just one pathway very specifically doesn't hit those other pathways that are contributing to disease.
That was excellent. Thank you, because I'm starting to get this. You're getting me all excited here. Now, we talked about the targets, but I know that when you use these oral medications, there's also the issue of interaction with other medications. And, I know that as a clinician, I really enjoy using the biologics because they're very clean, right? You can pretty much, it's very rare that you find some interaction like that. How are the JAK inhibitors as a class in that sense?
Yeah, so you hit on a really important point. When we're looking at the pros and cons of, biologic, for example, versus the JAK inhibitors, one of the primary advantages to the JAK inhibitors for some patients is that they really don't want to do an injection, or maybe they have a fear of needles, or they just don't want to go down that path for some reason, or maybe it's not even available from the insurance perspective, or it's too expensive. So the advantage for a patient is that they can take an oral medication, but you also hit on the disadvantages, which is that, unlike the biologics, they have drug-drug interactions, and there can be some, really important ones that we want to pay attention to. I think the primary group that we want to look at for, medications that are going to be a problem are anything that also requires the liver to metabolize them, right? So there are some medications which can either induce or sort of affect the metabolism of the JAK inhibitor, but vice versa. The JAK inhibitor can also affect the drug levels of another medication. And so those are definitely things that we have to think about. But it goes beyond that, because there are also problems with oral medications because there are other factors that can impact how well, the drug gets absorbed. For example, the GI system. So, not everybody absorbs medications orally the same way, and there's a lot of other conditions that can impact that. So we have to kind of think
Right.
about sort of those pros and cons when we're looking at, an oral small molecule versus, say, a biologic.
Jason, thank you for that overview, because really what kind of emerges to me is options. Now we have options. If I need to hit multiple targets, but I have to think about it. Do I want just one target? The selectivity concept. You hit on so many different concepts that are really important as we are trying to decide, okay, which medication would be the right medication for the patient in front of me. So I was wondering if we can maybe switch gears and maybe give an example with psoriasis, which is your favorite disease on the planet. And maybe we can back up for a second and conceptually just think about, why do the JAK inhibitors or the JAK-STAT pathway makes a lot of sense when it comes to psoriasis?
Yeah, I think this is a good place to take the concept and now say, now let's apply it to our patients. So remember this, the big concept is that the cytokines that we talk about, IL-17, IL-23, IL-4 and 13 for different conditions, they can't move inside the cell. So they need the JAK-STAT pathway to transmit their signal. When it's high, they interact with our T cells or other skin cells, for example. They pass a signal inside to make a change, whether that's a protective change or an inflammatory change, depends on the signal. But again, we need the JAK-STAT pathway to help communicate that signal. So the idea is that one of the ways of disrupting the cycle that's leading to psoriasis is either by blocking the cytokine causing a problem, or working downstream from the cytokine and blocking the signaling pathway that's also leading to that change causing psoriasis. So when we look at the JAK inhibitors, we know that the cytokines that cause psoriasis rely on the JAK inhibitor. So for example, when we start talking about IL-23 and IL-12, we know that the JAK inhibitors are critically important, that those two cytokines depend on JAK-STAT signaling. And one of the isoforms that is important for IL-12 and IL-23 is actually the TYK2 isoform. Now, it's kind of an interesting concept, because when you think about how the JAK inhibitors work, there's four of them, the JAK isoforms. So which cytokine signals in the body is really dependent on which pair you have together. So when you have TYK2 paired up with JAK2, that's what is required to signal downstream for IL-12 and IL-23. So again, you can block the cytokine or you can block either JAK2 or TYK2 to impact these primary cytokines. One of the reasons that TYK2 got developed over JAK2 is because it just so happens that JAK2 is critically important for hematopoiesis. So when you can block JAK2 and it would affect the downstream signaling of IL-12 and 23, which would be beneficial for our patient with psoriasis. But you're going to have also the new problem of the, potentially anemia or other blood cell problems. And so by blocking the other pair, we can avoid the blood problems, the hematopoietic problems, but still have an impact on the downstream signaling. So this was really the primary reason that TYK2 is being developed, and probably very shortly we're going to see an approval, probably this year for sure. But I think this is the main reason to think about why JAK inhibitors work in psoriasis, because this is really the key signal or isoform required to transmit the primary signal for psoriasis.
You know what's really interesting about this space is that just like the biologics, the original biologics, we didn't dial it in as much until like we got later and later, and then the biologics got really dialed in. And so, we say specific, but sometimes even specifically hitting something has a lot of different side effects. I feel like in the JAK inhibitor space, we may see this starting to come up, just like you're saying, managing the side effects. Can we affect the other pair? Can we address maybe one of the participants or maybe a subvariant of the participant and then reduce side effects? Which brings me to my next question. What are the side effects that we should be concerned about with JAK inhibitors? And more specifically, if you don't mind adding this in, how do you counsel this when you're talking to patients and figuring out, how to talk through the safety concerns that might arise with JAK inhibitors?
Yeah, I think this is going to be the primary clinical issue. So from a scientific and immunology standpoint, we know that, effective blockade of TYK2, for example, can be quite effective at decreasing IL-23. And by blocking IL-23, we know we can block IL-17. And so there's this concept is really clear, and we know it works for a lot of patients. There's some caveats, we'll come to that in terms of the signaling maybe later, but in terms of counseling patients, what we have to talk to them about is we're not just blocking the psoriasis cytokines. So we might also be blocking, other signals. Again, there's redundancy in how these isoforms are shared inside the cells. And so the primary side effect we need to talk about, number one, is that compared to some of the more specific biologics, it's going to have a broader impact on the immune response. So number one, we're going to see more immunosuppression, which theoretically increases your risk for infection. So that's going to be the primary issue that we want to talk about. And that makes sense when you think about you're blocking more immune protection potentially. And so you've kind of handcuffed your immune system to respond to, infections, viruses, bacteria, etc. So that's going to be the primary thing, is monitoring for infection. The other thing is that any of the oral medications can potentially have some GI side effects. So, there's a small proportion of patients that maybe had a little bit of nausea or diarrhea, and those are always tough because they're going to be hard to separate out from, non-medication things just because they're common. So we see that in a lot of clinical trials. Headache, upper respiratory infection, nasal pharyngitis, they're across the board because these are common things. And some of the GI aspects are probably some of that, but some patients, just don't tolerate the medication well. And the other big issue is, which I think is probably the most unique to this class of medications, is acne. So anywhere between 5 and 15%, we're seeing patients who are developing acne. And this is a little bit muddy, I'll say, because quite frankly, the companies haven't done a very good job of sort of managing the patients who get it in terms of collecting the information. Are they male? Are they female? Did they have acne before? Is this hormonal acne that's mostly along the jawline and the chin? Is it their back? Is it comedonal? Is it pustular? So we don't have a lot of information there, but it does appear this seems to be the most important, probably specific side effect that we see with this class of medication. And there's been a whole host of black box warnings that it's unclear how strongly linked to the medication they are. For example, blood clots, there's a warning there. Malignancy, those are things that we're not going to know until long term, but these are very low signals, unclear how directly they are tied to this class of medications, as opposed to people who have other risk factors that, for clots, for example, so diabetes, smoking, hypertension, sedentary lifestyle, those are things that already increase your risk for blood clots. So again, we have to take out some of those confounders, and we're not quite there. So I think probably serious infections, GI side effects, the possibility of acne, and then really monitoring these patients for other new symptoms. And probably one other one you'll see most commonly is these medications can make your cholesterol, your lipids elevated. So we do screen and kind of monitor that over time.
Hey, Jason, there's also some uptick in the Zoster flares with this.
So I think probably the best data we had was with tofacitinib, which is probably the closest thing we had to a pan-JAK inhibitor. It was mostly JAK1 and JAK3, but a little bit of JAK2 and TYK2, less so for those two. But we saw certain patients that had, elevated viral infections, so herpes and zoster. And so there's this idea that some of the other cytokines that are important for protection against viruses, get hit sort of, as collateral damage when we use these medications. But again, they're pretty low, but we do see, sort of viral infections. What's interesting is that we also see them with other sort of immunosuppressant medications as well. And so, again, it's a low risk, but we don't see a lot of serious infections. I think that's the main thing. A lot of these are mild infections, but we do want to watch for, increased both herpes infections and also herpes zoster.
So, Jason, I think, putting all this into perspective, thanks for this awesome overview, just taking us through the background, some of the, factors involved in just being what it means to be specific, selective, and the safety. Now, let's talk about just clinical practice. What is the scenario where you might reach for a JAK inhibitor? And can you discuss the speed at which JAK inhibitors work compared to, say, some of the biologics? What are your thoughts on that? And can you put it into that gray area of clinical practice and how you'd approach it?
If you don't mind, Jason, also give us some idea on the efficacy. I know that some of these are in earlier trials, some of these are already on the market, but what are the kind of, not to quote directly, PASI scores in psoriasis, for example, but what kind of efficacy are we talking about? So how effective, how fast, and then how does it play out, as Roger said?
Yeah, so I think looking at the sort of speed of onset, maybe one of the things that I think the marketers of these drugs will really push, right? These are fast-acting medications. I would always argue that speed's not a really critical factor, especially when we're talking about chronic diseases. Many of these patients that come in, and we'll get to a specific clinical scenario, these have been patients that have had disease for 10, 15, 20, 25 years. Some are new onset, but for the most part, they've kind of been dealing with this long term. So whether a medication gets them better in 2 weeks or 4 weeks faster isn't a primary concern. They like to have the speed of onset, but I think more importantly, they want to get to what you're asking about, Hadar, which is that how well does this work over time and is it sustainable? So one, I think, we do talk about one of the advantages of the speed of these medications compared to other biologics, but a lot of the biologics are pretty quick, but we're starting to see people, somewhere in that 40-50% of people getting better, between 4 and 8 weeks. And so they do tend to have a pretty quick onset, but we start to see the benefit long term kind of go, up over 3 months. They keep going up into about 6 months. So I'd say that most people are going to have a response within 4 to 8 weeks. So within 1 to 2 months, we're going to start seeing improvement. But I think, what's harder is when do you pull for one of these medications? So I'll just sort of leave you with a scenario of, people that will suggest that we've, figured everything out in psoriasis. We have all these great biologics. Why do we need to go back to a medication that's broad acting and has more potential problems? And I think the scenario that we can use are these patients that have both psoriasis and psoriatic arthritis. Because what I'll often see with some of these patients is we'll put them on a biologic and their skin will get better but their joint disease just isn't responding to the medication, or they have a little bit of improvement and their just joints aren't getting better. So they're painful, they're swollen, they're tender. And so, we can move around within the biologics. And sometimes what we'll see is that the newer medications just don't have as good of activity in the joints, but they're great in the skin. And so sometimes we'll go back, to a medication like the TNF inhibitors where we get a little bit better improvement in the joints, but it's not as good in the skin. And some of those patients don't respond to the TNF inhibitors, or maybe they've already tried them. And so you've got a patient that's tried the TNF inhibitors, tried multiple biologics, and you can get their skin better, but their joint disease is really causing a problem. And, understandably so, they may not want to go on a medication like methotrexate, which can have the long-term, liver fibrosis and, the nausea, for example. So these are patients where I think about being good options where we have one medication that has the ability to potentially treat both skin and joints. And so these are patients where I'm thinking about them as, one, they're eligible for systemic medications, or they've had an inadequate response to, multiple biologics, or for whatever reason, they can't go on biologics, but they don't want to be on cyclosporin or methotrexate, or maybe they didn't tolerate, Premolast, for example. Then I think these are patients where we might actually want a little bit of the broader acting mechanism of a JAK inhibitor because the really specific nature of a biologic didn't work well. And so because we know multiple pathways can feed into psoriatic arthritis, which tends to be a little bit messier of a disease immunologically compared to the skin, this might be a really good patient to go down the JAK inhibitor space. And so I've had a few of these patients where we've sort of done exactly that, trying to get them into treatment or into the trials for that reason, because they really haven't had adequate response to these highly specific therapies. So that would be a good clinical scenario where we'd have that discussion, where backing up a little bit in terms of broadening the mechanism of action can have a huge clinical impact and benefit for them.
I love this discussion. Also, I know we're talking about psoriasis, but one of the advantages of these JAK inhibitors is that, now we finally have something that we as clinicians can say, hey, if there's another condition out there that might be autoimmune or something, we can try to, use these things off label. And I feel like this is what happened even originally with thinking about tofacitinib. We tried to use things off label, and then finally, you go get the FDA approvals and the drug companies really work into it. Jason, what excites you the most about the JAK inhibitors? And what do you think is an area that's going to be of growth within the JAK inhibitor space?
Yeah, just a little teaser of an idea I've sort of been thinking about. One of the interesting concepts about psoriasis that's come out is this link between psoriasis and other comorbid conditions, or other conditions that seem to come as a result, or at least in strong association with psoriasis. So we have examples of cardiovascular disease, chronic kidney disease, diabetes, hypertension, sleep problems, mood disorders like anxiety, depression. So these are things that we think about as being directly related to having psoriasis. What's been interesting is that there's been, while we've picked this up and it's been sort of an epidemiological phenomenon, most of the treatments actually haven't altered their course of developing comorbidities over time. So I've been thinking about this idea that while the biologics get the psoriasis better, they don't seem to change your course much for cardiovascular risk or stroke risk and some of these other comorbidities that are important conditions that patients are worried about. So, I've been wondering about whether or not the broader mechanism of action of the JAK inhibitors might actually have an impact and modify the course of these patients in developing future comorbidities. Might it help protect them against other inflammatory conditions, or even inflammation in the vasculature, this cardiovascular disease risk? So those are all things that, we want to watch. Now, there's other side of that these JAK inhibitors could also worsen some of these comorbidities. So for example, we talked about the lipids with JAK inhibitors. So it raises the question whether patients on the JAK inhibitors will have better skin responses, but ultimately have worse outcomes with regards to their risk of, atherosclerosis, for example. So I think looking at how this class of molecules impacts the psoriasis-associated comorbidities will be really interesting and something that will come from years of study down the road. So that's an exciting area that I have been thinking about recently.
Wow, Jason, thank you so much. I mean, we went through so much. I feel like this is a topic and a conversation we could have had with a panel, and yet you just did it all on your own. That's unbelievable.
Hadar, I got one question for you though, my friend.
Yes.
Now, do you feel like you know JAK?
Oh, I know quite a bit of JAK, but if you out there don't know JAK, then you can listen to more of Jason as he's coming to the Integrative Dermatology Symposium.
Yes.
So he will be with us in Tucson, Arizona. And not only is he going to talk about JAK inhibitors and about psoriasis, he's going to be part of one of our panels. And he's just around. You can schmooze with him and learn firsthand what he does in clinic. So I think that's the best way to learn sometimes. And so really, thank you for your expertise. I mean, we went through so much. We really took the example of psoriasis, I think. But, as you read more about these medications, there's so much potential for other diseases that are maybe less common, but really are devastating, like graft versus host disease and really almost pretty much deadly forms of dermatomyositis and other diseases that we've always left kind of the back shelf and said we have to take care of the masses. But these are really diseases that have significant impact and not a lot of solutions. So, more to come on this. Thank you, Jason, for your time, for your expertise, and I'm looking forward to seeing you in Tucson.
Yeah, thanks for having me, both of you, and looking forward to the meeting in Tucson and for a riveting discussion and panel as we get into this a little deeper. It's always good to do this in person. So we'll see you guys there.
Hey, Raja, do you know where the integrative medicine movement started?
According to Google, since Google knows everything, Dr. Andrew Weil founded the Center for Integrative Medicine at the University of Arizona in Tucson back in 1994. Why do you ask?
Well, you know how we always try to get to the root cause? I think we need to go big for the fifth annual Integrative Dermatology Symposium. How about we do this? Let's meet at the Los Ventana Canyon Resort in Tucson, Arizona. Or you can join virtually from September 30th to October 2nd and hear from the world-renowned experts like Andrew Weil.
Exciting. And our theme is connecting mind, body, and spirit to take a more holistic approach to our patient care. What do you say?
Absolutely. I mean, where else can you get the latest on diet and dermatology, hypnosis, botanicals, common diseases, aesthetics, and other unique topics in dermatology with practical takeaways to start using in clinic right away?
So true. And let's not forget, we've got the new track for estheticians too. I think I'm going to need to call in a sick day or two before the symposium so I can enjoy the waterfall and trails on the resort, stargaze, play a round or two of golf or tennis, relax at the spa, and catch up with colleagues at the evening receptions.
Yes, that place is spectacular. Use our discount code POD25 at checkout for 25% off.